Welcome everybody to March 2024 Rehabilitation and Movement Science Grand Rounds. So this month we have with us Dr. Alex Stiverson. Dr. Stiverson earned his Bachelor of Science in Kinesiology from Pennsylvania State University and his Doctor of Physical Therapy from the University of Sciences in Philadelphia. He's board certified in orthopedic physical therapy and is currently a fellow in training at the St. Luke's University Health Network Spine Physical Therapy Fellowship. Dr. Stiverson's treatment philosophy includes providing the patient the tools they need to manage their problem and is constantly working toward developing a healthy and active lifestyle for his patients. He's going to be talking to us today about interdisciplinary collaboration in low back pain and identifying key indicators in coordinated patient care. If you're tuning in live, please make sure you sign into EADS either using the sign-in code or using the QR code. And I also placed it in the chat box for your reference as well. This is our activity statement description and statement of need, and it's for all providers. This is the St. Luke's University Health Network designation statement, and the planners and presenters have nothing to disclose. So without further ado, I will turn it over to Dr. Stiverson.
All right. You guys see me okay? So like Steve said, my presentation today is going to be on interdisciplinary collaboration in low back pain. The reason I wanted to do this presentation is I feel as physical therapists, we sometimes get, and not even just physical therapists, probably any discipline, we sort of get stuck in our own niche, our own kind of silo, and we sort of lose the bigger picture. And I feel like when we're trying to collaborate, we really do need to understand that bigger picture better, right? So I talked to a lot of physical therapists. I talked to a pain management physician. I talked to a psychologist, just to try to work to put this all together for you. And honestly, I'd say I learned a lot, and hopefully I can share some of that with you today. So my objectives. So first, we're going to just review the fact that low back pain is complex and multimodal in nature. And then we're going to work to hopefully identify some indicators or things you can look for that are going to cue you into potentially, collaborating with other providers, right? To do that effectively, we need to, like I kind of already said, we need to understand what those providers offer. So I want to review that as well. Inevitably, the goal is going to be, of course, to somehow apply this into your own practice, through your own practice, and then maybe even through some examples that I'm going to have today. So establishing the problem, I mean, we all know that low back pain, especially chronic low back pain, is a huge problem that remains the leading cause of years lost due to disability. By the year 2050, there'll be 36% more low back pain cases. That's not necessarily because we're getting worse at treating it. It's actually more to do with the growing population, but still more and more cases of low back pain. Current data suggests that 32% of acute low back pain cases will turn into chronic problems, which is, of course, the biggest strain on our medical system. So. Just a little stat from the CDC I use all the time with my patients. So 39% of adults over age 18 or older will have back pain in the last, have had back pain in the last 3 months. The reason I use this statistic is I feel like it just highlights how normal and common back pain is, right? So again, one of the objectives today is to give an overview or a review on the complex multimodal nature of low back pain. If you don't know what the Lancet is, it's one of the most respected and referenced medical/science journals in the world, right? They did a seminar series in 2021, which was just a bunch of really, really smart people getting together and talking about kind of where we are with low back pain. If you treat low back pain, you should read this article if you haven't. It's great, but just some key points from some of the stuff that they discussed. So first of all, lower back pain includes various types of pain, nociceptive, neuropathic, nociplastic. If you don't know what that is, I encourage you to read this article. There remains a low specificity of diagnostic imaging. So basically it's still hard to figure out through imaging how a patient is going to present, or imaging, of course, as we know, doesn't usually describe a patient's clinical presentation. And then this was just a really good quote from that article that I feel like they just put really well. So I'm just going to read it. It is important to understand pain is distinct from nociception and includes not just A delta fiber and C delta fiber, but also context-dependent emotional, cognitive, and behavioral elements. So what they're referencing there, of course, is the biopsychosocial model. The biopsychosocial model is probably the best tool we have currently to explain chronic low back pain. Here's just an example of it. Another really good quote from the article, basically just saying that somebody's pain experience or low back pain is a dynamic interaction between social, psychological, and biological factors, right? And when we're considering a interdisciplinary treatment plan, okay, we need to consider all of these factors from the biopsychosocial model. So what do we get from this? Well, low back pain is complicated, right? Obviously, we know that. Can one provider handle all of these components? Is there one provider that is an expert in all of this? As a physical therapist, I'm biased, of course, and I'm going to say that we do a lot of this, certainly. But are we experts in all of it? I mean, obviously not, right? So if we are going to include multiple providers, we have to consider, first of all, who's going to work to direct that care? How involved are we in that, right? Okay. Well, moving on. So over the last 20 plus years, there's just been overwhelming data to show that physical therapists are safe, cost-effective at providing primary care for musculoskeletal issues, right? Clark B, this study here, it was a systematic review of tons of research over the last forever about how good we are at doing this. And PTs in the military have been doing it, obviously, for a long, long time. Not only that, but the Association of American Medical Colleges estimates that there's going to be an even greater shortage of primary care providers by 2033. Okay. That same Lancet article, again, we're talking about one of the most well-respected medical and science journals in the world in 2021, specifically called for an increased emphasis on PT as a first-line treatment. So putting this all together, when we're considering, interdisciplinary treatment plans and who's going to work to coordinate and suggest patients go see other, what profession, what discipline makes the most sense to coordinate all these things together? I don't know. I would say maybe us, right? But can we do it alone? I mean, again, we're not experts in every single one of these components, right? The biopsychosocial model, there's a lot of elements here, and we know chronic low back pain is complicated. So can we do it alone? No, of course not, right? So interdisciplinary collaboration is so important for chronic low back pain. Hopefully you understand that, right? In putting this presentation together, I wanted to answer a question for you, right? It makes sense, right, that multidisciplinary care should be more effective, but is it actually? Do we have research to back this up? Well, what I did is I did a extremely deep dive into the literature, and purposefully staying away from my own biases, I looked at so many different international guidelines, internet guidelines from literally everywhere, deep dive, trying to answer this question for you. Is multidisciplinary care more effective in the management of chronic low back pain? Well, I think you know the answer. I mean, there's not much these guidelines, which is just crazy, but there's not much these guidelines agree on. There's so much contradiction, so much conflicting evidence, because back pain is so complicated. But one of the few things consistently these guidelines agree on is that multidisciplinary care is a good thing for chronic low back pain. So including other providers, having more than one provider in providing consistent messaging between providers is such a good thing in the management of chronic low back pain. So NASS, for example, it's literally in the title. The DoD, I just thought they put this really well. So for patients with chronic low back pain, we suggest a multidisciplinary or interdisciplinary program. These programs should include one physical component, right? So, includes one physical component, probably us, and at least one other component of the biopsychosocial model used in an explicitly coordinated manner. Okay, and I just thought they put that really, really well. The European Spine Journal did a systematic review of a number of different international guidelines, and then in reference to multidisciplinary care, basically, again, consistently, all of them recommended it. So 9 out of 11 recommended a multidisciplinary approach to chronic low back pain. 1 out of 11 recommended multidisciplinary approach for chronic and acute low back pain. And then 1 of 11 recommended a multidisciplinary approach when monodisciplinary approaches don't work. But still, all 11 of these international guidelines recommended a multidisciplinary approach to back pain. So putting this all together, we as physical therapists, it's been encouraged that we are the first line of defense, that first line treatment. We're really safe at doing that. Back pain is super complicated. A multidisciplinary approach is a really good thing. So let me ask you this. Do you know when to collaborate? Do you know when it's most appropriate? If somebody is coming to see you directly, do you know when it is most appropriate to include another provider? Well, let's see. So I have a case example here, pretty basic, but we have a 28-year-old male lifter. Pain began 4 days ago, after a hard workout. We had a hard workout 4 days ago. He has 6 out of 10 right paracentral low back pain. He ends up in direct access physical therapy a week later. Basically, all movements increases pain, and he wants to get back to lifting. No ridiculous symptoms, no obvious red flags. Very, very simple, basic case here, right? So what do you do? Do we need to collaborate? Do we need to include other providers? This is a true case of acute low back pain, right? And true acute low back pain has a pretty good prognosis. The first line of defense might be, hey, I know you want to get back to the gym. Please go back. Just maybe keep the weight a little bit light. Maybe spend a little bit more time doing cardio. This will get better. Maybe you strained a muscle. Okay. Maybe provide them 1 or 2 exercises as active management strategies. But this is the true first line defense as far as acute low back pain goes, right? Any provider can do this, whether you're a physical therapist, primary care provider, orthopedic surgeon, anybody can do this. And do we need collaboration here? I mean, no, probably not. I mean, this is a simple case of acute low back pain. We probably don't need to collaborate. But I'd like to introduce a concept to you if you're not aware of it, right? So this is an expert consensus from that same systematic review from the European Spine Journal. So with chronic low back pain, and then I bolded this, low back pain at risk for chronicity. So in this case, what they mean is acute low back pain at risk for chronicity. It is useful to consider a multidisciplinary management. So even though our weightlifter, who doesn't maybe have any obvious affective tendencies, or maybe he's really in pretty good shape and no obvious comorbidities, even if he is not at risk probably into having a more chronic issue, there may be people that are, right? So even though for this patient, probably don't need a multidisciplinary approach, there are cases of acute low back pain that maybe based on their risk for chronicity, we do, right? So how do we screen for this? Well, in our comprehensive spine program, we use a tool called the Start Back tool. It's really well researched. It has a lot of good data that backs it up. And to some degree, it is able to help predict who is more at risk for their acute problem, their acute low back pain to cascade into a chronic issue. Right. This article from JAMA also highlighted a couple other things that may be predictive of, a patient kind of having a more chronic issue with their acute pain, and that's obesity, smoking, depression, anxiety, and then severe baseline disability. So most cases of acute low back pain, we probably don't need to consider a multidisciplinary approach. But if somebody is really very high risk for chronicity, it probably should be, to some degree, potentially on your radar, right? So 32%, overall, 32% of acute low back pain cases turn into a chronic issue. So let's go back to our weightlifter here. So you did everything right based on the literature. You gave him the appropriate exercises and you gave him the right active management strategies. You reassured him, did all the right stuff. Unfortunately, still, maybe even gave him your card. You said, hey, email me if you have problems, right? But unfortunately, 32% of these cases, maybe less if he's a low risk category, but still a good portion of these cases do turn into chronic issues. So now it's 7 months later, this patient returns to direct access physical therapy. The pain is in the exact same spot. It's still a 6 out of 10. Sometimes maybe it kind of goes to the other side too, the other glute, we'll say. He can stand for 10 minutes, sit for 15 minutes where the pain is just real bad. Gets better with exercise, but doesn't really get better with rest. He lost his job, okay? Pain's too bad, and it wakes him up 2 to 3 times per night. What do we do now? Do we just do PT? Do we ask for help right away? Right? Do we do PT, and then if that fails, we send him to the next one, right? Well, this is now a chronic back pain, obviously, right? And we just learned, hopefully, that for chronic back pain, a multidisciplinary approach is a really good thing, right? But when? Okay, when do we collaborate? With who do we collaborate? Again, do we only do it after PT has failed? Does it depend on the patient? Okay. Are there key indicators? Are there things that we can look for in the literature that are going to clearly answer these questions for us? Right. It was my goal of this presentation. I wanted clear and concise things that are going to help us determine when we send a patient to X, Y, or Z. So I went back to the guidelines. Another deep dive, trying to determine this. And unfortunately, there really isn't a clear consensus. There isn't a clear consensus on when we should include other providers if we are that first provider seen. There's not necessarily a clear consensus in how a patient has to present for us to send them to another provider. So, but we know a multidisciplinary approach is a really good thing. So how do we know when? How do we know when to collaborate? Well, I would argue first, and probably most importantly, again, the whole reason I wanted to do this presentation, which is we need to understand the overall medical management of low back pain. We need to understand what other providers do to better help our patients and maybe give them the appropriate suggestions as far as when to collaborate or when to go see another provider. And then, even though the research doesn't provide it, maybe there are some indicators based on experience, and maybe there are some indicators that we can look for that may suggest that we should include another provider, maybe along with PT or instead of. Chronic low back pain is multimodal, okay? It is complicated. Even if we're not sure on if it's appropriate to collaborate, we know that based on what I just told you, a multidisciplinary approach is a really good thing. Okay, when we include other providers and those providers provide consistent messaging to that patient, outcomes tend to be better. So even if you're not sure, again, remember, it's probably a good thing to do. So we're going to go over a couple other providers and maybe just really briefly touch on some of the things that they may do to help manage some or help a patient with chronic low back pain. We're going to touch on some of the more common potential referrals for back pain. So pain management, neurosurgery, and orthospine surgery. So for our cases here, we're going to consider neurosurgery and orthospine surgery the same. and then rheumatology and behavioral health. So we're going to start with pain management. So first of all, so what is pain management? So I just want to say, this group here at St. Luke's, I mean, every interaction I've had with them has just been so positive. They've been so helpful, educational, compassionate with their patients. It's just really cool. I feel lucky that we have them on our side for a lot of the stuff we do. But even one helped me put this presentation together to some degree. I mean, he answered some questions, but still, I mean, so what is pain management? So pain management is a group of physicians that specialize in treating pain, whether that's acute pain, chronic pain, whether that's pharmacological management or specific procedures. And like I said in the beginning, I think it's important we understand some of the more common procedures and things that they'll do with the patient so we can better help our patients, and then understand when somebody could benefit from seeing a pain management physician. So to be clear, they do a lot more than this, but I want to go over some of the more common procedures that a pain management physician would do for somebody with chronic or acute low back pain or radicular pain. So epidural steroid injections, spinal cord nerve stimulations, or lumbar medial branch radiofrequency neurotomy, or nerve ablations. So we're going to start with epidural steroid injections. So just really brief, I'm sure everybody has at least a basic understanding of what these are, but there are transforaminal, translaminar, and caudal. Probably won't see caudal too much, but please just understand that is the approach of the needle. That's all that means. So for all our purposes, it's maybe not all that important. In the notes, you may see TF ESI or TL ESI. Epidural, of course, meaning around the dura. Steroids with the goal of reducing inflammation, and then with or without. This is done with or without a local anesthetic. So when does it work? So Helmut All did a study in 2021. It was a big systematic review. Basically, his findings there were these injections are excellent for radicular pain caused by disc herniations. They really work well. So for radicular pain, an epidural steroid injection can work pretty well. And now that's acute pain or maybe even more subacute or chronic radicular symptoms. These can work well. For axial pain, maybe not as much, but there's other interventions or procedures for that. So we're going to go over radiofrequency ablation. This is the second most common procedure performed in pain practices for the management of chronic low back pain. What they'll do is, through a physical examination and through imaging, the physician will suspect a patient's pain is coming from a specific level, or a specific, in this case, we'll say facet. That facet has a nerve that supplies it, right? So what they'll do is they will do what's called a medial branch block. You can think of it as numbing. So they basically numb that facet. And then over the next 24, 48 plus hours, they'll assess the patient's relief of pain. Okay, if the patient gets excellent relief of pain, we've at least diagnosed the level or the spot of pain, as we know, or at least part of what's contributing to their pain. As we know, doing that when it comes to low back pain is not an easy thing to do. So if the physicians can successfully diagnose a level, then what they'll do is they'll go back with electrodes, which targeted radio waves, whatever they are, they create heat, and they'll basically destroy that same nerve that they numbed. Now, this isn't permanent. Nerves grow back. They may grow back over the course of a year, but this can work for axial pain. The guidelines from the American Society of Pain and Neuroscience say that when you have a successful nerve block and a successful medial branch block, it makes sense to do a radiofrequency ablation, or a patient probably will have success with a radiofrequency ablation with that successful diagnostic nerve block. Okay. Briefly going to touch on this. So spinal cord stimulation, I think we all to some degree understand what this is. It's basically electrodes that are inserted into the epidural space. And then attached to those electrodes is a pulse generator that's placed under the skin. A lot of the research that exists for this is with failed back surgery syndrome, quote unquote. It's essentially exactly what it sounds like. Maybe a patient has had 1, 2, 3 back surgeries and still has pain. This potentially could work well for them. So in quick summary, so who are we looking to send to pain management? Again, in that direct access role, we're the first person to see, or the first provider to see that patient. When are we looking to send somebody to see our pain management colleagues? Well, first of all, we're looking for a relatively stable clinical picture. If somebody has, say, urinary retention and progressing myotomal weakness, you're not going to send them to pain management. So the picture is overly stable. Maybe the pain's getting slightly worse or staying the same, and they're still in pain, right? That could be while they're actively participating in PT. That could be after. It doesn't need to be after. Please understand that. In fact, there is some research that says there are certain patients that may do better in PT. They may do better in PT after having received an epidural steroid injection, or maybe after having their pain a little bit better controlled. We don't need to be exclusive from pain management. In fact, these guys, they advocate for us so much. If you have a patient, you send them to pain management, and you say, and that patient says to them, "Oh yeah, I've been going to PT." Pain management like, "Oh good, I would have sent you there anyway." We can work together. It doesn't need to be exclusive. If there is an obvious inflammatory component to the pain, all movements hurt. They can't do anything in PT. This is even if the pain is relatively acute or those radicular symptoms are relatively acute, okay? It makes total sense to have them consult with or to collaborate with a pain management provider, pain management physician. Okay, and then just reviewing, epidural steroid injections are great for radicular symptoms. Radiofrequency ablations are potentially good for axial pain, and then spinal cord stimulation, may help somebody after failed surgery. Okay, next, spine surgery. So we're talking about neurosurgery and orthopedic spine surgery. So there's certainly situations here where there are clear indicators. There are things that we are looking for that really suggest that somebody not only should go to surgery, but probably needs surgery. And I think those are relatively clear. We are all hopefully to some degree familiar with red flags, right? What we consider red flags. So I listed a couple, right? Newer onset increasing myotomal weakness, severe neurologic findings, central signs, urinary retention or changes in bowel and bladder, and then saddle anesthesia. I mean, I think we all understand if we have a patient who comes in with progressing myotomal weakness, saddle anesthesia, and urinary retention, hopefully we know where to send that patient and where to send that patient quickly, right? Hopefully. The gray is a little more hard, right? Finicane in 2021 published an article in JOSPT. He described this kind of sliding bar here. And that sliding bar is the overall clinical picture and your level of concern. So some of these elements that I have here create that overall clinical picture. And based on that overall clinical picture, you have this sliding bar. If we're all the way over to the right, meaning we're really concerned something is not right here, that's when you send somebody to surgery. If you are unclear about understanding, red flags and some of these things I just talked about, I encourage you to read the article. It's pretty good, relatively easy to digest. Okay, again, if somebody comes in to see you and they tell you they have urinary retention and saddle anesthesia and their gait's changing significantly, we'll say, we know where to send that patient. But what if it's a little bit more gray? Well, one of the guidelines that I went over, the NICE guidelines from 2016, recommends surgery when everything else has failed. In my head, that means you've tried multiple physical therapists. You've done all the injections. You've tried maybe even, if it's relevant, behavioral health. You've done everything. In those cases, I mean, surgery may be all that's left for these patients. And I think we probably all understand that. That same Lancet article in 2021, the one, again, some of the smartest people in the world talking about, smartest physicians and researchers in the world talking about low back pain challenge the relevance of decompression and fusion surgery as it relates to low back pain. In instances of severe instabilities, progressive neurologic symptoms, I mean, of course, right? Nobody's going to argue the relevance there, but with low back pain, there remains conflicting evidence. One of the things, though, that was interesting in the NICE guidelines is they did mention that when radiographic findings are consistent with radicular symptoms, surgery may actually be a good thing. So in answering this question, is it only failed conservative management and concerning clinical picture that is going to indicate somebody for surgery? Oh, I have an example. So if you can't see my picture very well, I apologize, but fortunately we have a radiologist report. So L4, L5, left foraminal disc prolapse with L4 nerve root impingement. That's what we're looking at, okay? That patient has this, and they also, the rest of the MRI we'll just say is relatively clean, okay? On top of this imaging finding, they also have pain on the right side of their back, weakness in hip flexion, an inconsistent Achilles reflex, and then stable symptoms for the last year. Okay. Does this MRI explain these symptoms? Should this patient, I mean, is surgery a good option for them? If they fix this, this significant disc prolapse, is that going to address these things? No, obviously not. I mean, the disc prolapse is on the left, pain's on the right, hip flexion is not L4, an inconsistent reflex, Achilles reflex is not explained by L4 nerve root impingement, and these had stable symptoms. So in this case, imaging probably encourages the fact that, no, this patient probably should go to pain management, okay? Doesn't seem, considering the fact that we'll say the rest of the MRI was clean, this doesn't seem like fixing that is going to do anything for this patient, probably, right? But what about now? So L4 nerve root impingement, we'll say significant L4 nerve root impingement, pain and paresthesia in the medial shin and lower leg, weakness in dorsiflexion, decreased patellar reflex, and then a 3-month history of very gradually worsening symptoms. Does this MRI finding, does that influence your decision on who this patient should see and the urgency of seeing that person, that provider? Is surgery what is best for this patient? According to the NICE guidelines in 2016, maybe, okay? We do a lot of education to, say to a patient, I know you presented with X, Y, and Z on your x-ray, but everybody kind of presents with that. And in many cases, that's totally appropriate. But I think as a result, maybe I'm probably guilty of this, we sort of completely dismiss the usefulness of imaging, and that's not appropriate. Okay, there are situations where it may, to some degree, influence your decision on the urgency a patient needs to see a different provider, or maybe to the contrary. So, just reviewing, there remains controversy on if surgery should be done for just pain. The guidelines, all the guidelines that I dove into for you, remain, very unclear. Okay, we need to be aware of red flags, but we also need to be aware of the entire clinical picture. Don't completely dismiss imaging. If symptoms match the image well, I mean, you may want to consider that patient seeing a safe surgeon sooner, encouraging them to see a surgeon sooner rather than later. And then, of course, we know, I'm sure, when all else has failed, surgery may be all that's left, right? Next, we're going to briefly touch on behavioral health. So in the guidelines all those guidelines that I described, and I took a deep dive into, there are very few things, alarmingly very few things that they all sort of agree on. Again, going back into the very complex nature of low back pain, right? One of the things they agree on, as I already described, is multidisciplinary care is a good thing, okay? That's number one. Number two, general exercise is good for chronic low back pain. Nobody really seems to disagree with that. Number 3, cognitive behavioral therapy is a good thing for chronic low back pain. Okay. So what is it? Cognitive behavioral therapy is a psychological treatment done by potentially a psychologist, of course, right? This is the 3 general overarching principles of it. This is from the American Psychological Association. Problems are based on faulty or unhelpful ways of thinking. Problems are based on learned patterns of unhelpful behavior, and then they're providing coping strategies to these problems. So cognitive behavioral therapy is technically, of course, done by a professional trained in cognitive behavioral therapy, right? But let me ask you, do we use some of these principles? I mean, if you have treated chronic pain, I'm sure you naturally have. Maybe you don't even realize it, but pain neuroscience education, active management strategies, activity modifications, promoting self-efficacy, is this not to some degree hitting these core principles? I would say yes. Now, there may be some of us that are better at doing these things than others in our own profession, in which case I'd encourage you to send your patients to that PT, that professional provider. We have some outcome measures, some of which I've already touched on, to determine how depressed, anxious, a patient is, how likely they are to, based on a psychological subset, how likely they are to have chronic issues, low back pain, right? So we have these tools available to us. And if patient scores very poorly in some, maybe we need to follow up, right? Chronic low back pain is, again, a very complex problem, and anxiety, depression, is so prevalent, right? It can affect the plan of care if you feel your care is not sufficient enough to address those, if the exercise isn't getting them there, if the pain neuroscience education isn't getting them there. It's very important, very appropriate to refer somebody to seeing a behavioral health specialist, right? This allows for one, right? We've learned multidisciplinary care is a really good thing. And it allows for consistent messaging between providers, right? You're telling the patient something, another provider is telling the patient something. Outcomes are going to be better with that. And then, of course, behavioral health specialist who's trained in cognitive behavioral therapy. Cognitive behavioral therapy is a really good thing, and one of the few things these guidelines actually agree on. Next, rheumatology. To understand when somebody with back pain needs to see a rheumatologist, we need to understand this concept of inflammatory low back pain, the most common of which is ankylosing spondylitis, okay? And that's really what we're going to focus mostly on today. In these pathologies, early recognition is key. Before the patient gets the appropriate treatment, there is an active disease process going on that is progressing. The medication and the pharmacological management is working to arrest that progression, but before they get appropriately diagnosed, there is an active disease process. So early recognition for these individuals is important. It is so hard, though, right, to differentiate sometimes from inflammatory low back pain from common or mechanical low back pain, right? Back pain is complicated. There are some indicators that we can look for, and I'll go a little bit more into this today. Here are some of them. It's 3 times more likely in males too, and usually males in their 20s or 30s is when it gets diagnosed. But yeah. This is a chart from the New England Journal of Medicine in 2016, and there's a bunch of characteristics here, and what they're doing is they're listing the characteristics of inflammatory low back pain. If somebody has 4, according to this article and this chart from the New England Journal of Medicine, if somebody has 4 or more of these features, they can actually be diagnosed with inflammatory back pain. I would argue if somebody's diagnosed with inflammatory back pain, it is absolutely not just PT that they need. PT might be helpful, of course, but it's not just PT. They need to see a rheumatologist to be further evaluated, 100%. Okay, so this is probably a useful chart. 4 or more of these features is diagnostic of inflammatory back pain. Okay. There's more that can be done to appropriately diagnose ankylosing spondylitis specifically. There's some lab values that may or may not show during an acute flare. 90% of people with ankylosing spondylitis are positive for this gene here. In the early phases of ankylosing spondylitis, MRI can actually see, some issues around the sacrum or sacroiliitis. And then some of the later changes along the spine, that bamboo type spine that we see sometimes that I had a picture of earlier even, that is a more late change that happens with ankylosing spondylitis. And now this, I want you to be aware of this here. So the mean delay of diagnosis has been shown to be as much as 8 years with ankylosing spondylitis. And remember, like I had said, there is an active disease process going on before the patient gets the appropriate treatment. And currently, again, it's taking 8 years. So 8 years of somebody being tossed around the medical system, saying, it's just common low back pain, it's just mechanical low back pain, and it's just chronic pain, right? Before they get the appropriate treatment. We as physical therapists, I feel, are in such a good position to recognize, when something isn't actually mechanical, mechanical in nature, when there's something just doesn't quite seem right. And we spend a lot more time with our patients than a lot of providers do, and we talk to them a lot more. We talk to them a lot more, I'll say. Okay. We're in a good position to make that 8 years hopefully a little bit better as we continue to transition into a more prominent direct access or primary care role, right, as it relates to low back pain. So treatment for ankylosing spondylitis. So it's mostly pharmacological management. Okay. They really do need to be evaluated by a rheumatologist. What the rheumatologist will do is they'll determine if the disease is active or not active. Based on that, medication will change slightly. During the active phases, it's just continuous NSAID use. During the less active phases, it's more on demand. And then there's certain medications like TNF inhibitors with the goal of, kind of arresting that overall disease process. And then again, there will be active follow-up. So this patient is going to need to continue to see their rheumatologist over the course of however many years or whatever they work out in the plan of care. Okay. And then PT is good too. Actually the American College of Rheumatology highlights it. PT is a good thing too for these individuals. Okay. So I'd like to take a second to go back to our weightlifter. So he was, remember, 28 years old. It's now a chronic issue, 7 months after onset of pain. You're still the only provider that he has seen. The location is mostly the same, but remember, it's now radiating to either glute. He can stand for 10 minutes, sit for 15 minutes. Gets better with exercise, doesn't really get better with rest. He lost his job, and it wakes him up 2 to 3 times per night. So let me ask you again, after everything we just went over, what would you do? Would you just try PT and see what happens? Do we need to include another provider right away? Going back to that chart from the New England Journal of Medicine, okay, highlighting these characteristics of inflammatory low back pain, based on the information I have here, you could literally diagnose him with inflammatory low back pain. I would argue this patient needs to see a rheumatologist right away to be further screened for inflammatory low back pain and maybe ankylosing spondylitis to get the appropriate treatment and not get tossed around the medical system for 8 years. So in summary, please do not forget about inflammatory back pain. It is often diagnosed by primary care providers, and as we continue to step more and more into that primary care type role, it's important that we recognize this. Okay. Differentiating between mechanical and inflammatory low back pain is challenging, but a misdiagnosis significantly affects that patient's prognosis. Remember, the pharmacological management is trying to some degree, arrest that disease process, and the sooner they get on the medication, the better. Be aware of this criteria in the diagnosis of inflammatory low back pain, please. Okay. So you're not going to remember everything I said today, that's okay. But I want you to take away a couple key points. One, multidisciplinary care is better than monodisciplinary care for chronic low back pain. Remember, it's one of the few things that all of these guidelines agree on. Multidisciplinary care is better for chronic low back pain. If you're unsure, if you should be including another provider, if the issue is chronic, why not? Pain management isn't just for when somebody has failed PT. Please remember that. We can work together. And in some cases, working together may be the best thing for the patient, and their outcome may be better. Okay. We do a lot of education to say that imaging doesn't matter, but it does sometimes. So please be aware of that, especially when you're considering how appropriate somebody is potentially for a surgery. It may be the appropriate intervention. Very few things these guidelines agree on, like I told you, right? Cognitive behavioral therapy, however, is one of the few things that they do. So please be aware of that. And then finally, please don't forget about inflammatory back pain. So if all of this interested you, the comprehensive spine program here at St. Luke's is it's such a cool program to be more involved in, as that Lancet article in 2021 said, to really be that first line of defense for patients with back issues. I'm so excited to be a part of it, and I really think it's an excellent program for our profession, but also for our patients. Okay, if you've been asked to join, please consider it. It's great. A lot of the talk today has been on multidisciplinary care, but please be aware that even within our own profession, at least here at St. Luke's, we do have advanced spine care providers. There's a group of us that really like treating the spine, and we are always so willing to answer questions or receive a referral. If you have a patient that's really struggling, that you're really struggling with, but you really think physical therapy is the right answer, please don't hesitate to include us. Potentially the idea is we are kind of that next step in care, especially if somebody's not as relevant for surgery, or maybe even in some cases, epidural steroid injection, etc. So if you're really interested in the spine, like me, the Spine Fellowship here at St. Luke's is so cool. I mean, it's one of 4 accredited in the country. It has changed in the last 9 months. It has changed my practice so much, and I just foresee the rest of my career being honestly so much more satisfied, and I feel really grateful to be given this experience. I mean, the faculty has been so helpful, and I can only say great things about it. So if you have any questions for me about the fellowship, feel free to email me. I'll give you my number. We can talk, or you just email, whatever. And I'd be, like I said, happy to answer anything. So here's some references. Here's more references. And what questions do you have for me, Steve? How do I?
So either unmute yourself and ask, or type into the chat.
Hi, Alex. It's Melissa. How are you?
Hey, Melissa. I'm doing good. How are you?
I'm good. I know the answer to this question, but maybe some people who aren't in the spine fellowship may not know the answer to the question. It might be a simple question, but if you determine that the patient might be a candidate for surgery, how do you know who to refer to? Do you refer to a neurosurgeon or an orthopedic spine surgeon?
Honestly, refer to somebody you have a relationship with is probably your best bet. I mean, as far as the management of back pain goes, either one can be just as effective, and you should probably refer to the provider that you're most comfortable with or have the best relationship with, I would say. Does that make sense?
Yeah, good answer.
Cool. Thank you.
Awesome. Thank you for sharing all the various points to consider about how and when to refer, as well as what the other disciplines might do. How much of that would you explain? How much of that would you explain to the patient?
As far as what we're kind of looking at and what I would explain it all. I tend to have a style, personally at least, where I'm very transparent with what I'm seeing and what my thoughts are. So personally, I would explain everything to the patient.
What word instilling additional fear into the patient, or would you feel that just making sure that it's completely open and transparent?
Over the years, I've learned, you do have to be very careful with what you say. And, there's a certain art, certainly, that comes with experience in talking to our patients. And yes, you do have to be selective with your wording, and when you're explaining to a patient what your thoughts are. Absolutely. Right. And again, like I said, that to some degree, I think is kind of an art and comes with experience. So.
Another question, is there a list available of providers in and near the St. Luke's network that provide cognitive behavioral therapy?
I do not know the answer to that question. That would be a great resource, I would imagine. But I do not know the answer to that question. I can follow up and maybe, I don't know, what would we do? Email the group?
Yeah, so what I would say to that is the leader of the behavioral health department is Amy Allenson.
Okay.
Contact her. The other way if the patient either doesn't want to stay within the St. Luke's network, or if they're a little bit further away, if you look at on the website, there's psychotherapy.com or therapytoday.com has a resource of basically find a therapist, and you can look for psychotherapists that form cognitive behavioral therapy.
Great. Okay. Can they hear you?
They should be able to.
Okay, good. Okay. All right. So yeah, what he said, basically. So yeah, and we've talked before about, trying to develop, say, like a network of providers that you're comfortable referring to, somebody you can actually develop a relationship with. If you have in your area a provider, whether it's within the network or, like Steve said, maybe even outside of it, that performs cognitive behavioral therapy, I mean, it's a great resource and connection to have for, which will only benefit our patients.
Another comment is great job.
Thanks.
These are all great points and worth applying to our practice. Helping everyone think outside of our world is so
excellent. Okay. Yeah, thank you. Thank you. Whoever that was, thank you.
If you have any further questions, please feel free to reach out to Dr. Stiverson. And thank you very much for attending today. Make sure that when you're finished with this, you complete the quiz and the course evaluation so that you get CE or CME credits for this. Oh, here's a question.
Oh.
Thank you for your presentation for your 28-year-old weightlifter. How did his outcome come along?
Well, okay, let's say he saw a rheumatologist, got the appropriate treatment, came back to you, was extremely grateful that you gave him the appropriate diagnosis, and he's getting the appropriate treatment, and now he wants to see you for some follow-up physical therapy. So he's doing great.
All right.
Thank you.
Thank you very much. If you have any questions, please feel free to contact Dr. Stiverson.